Hello, good evening everyone and welcome to the EUROGEN webinar series. Before we get started, I'd like to take a couple of minutes to tell you what the ERN EUROGEN is and does. In 2017, 24 European reference networks were created by the European Commission, and they all aim to deal with patients with rare diseases and complex conditions. In EUROGEN, we deal with rare urogenital diseases and complex conditions that all need highly specialised surgery, so where the expertise is rare. And we focus on surgery. We're a surgical ERN. Some of our activities, one I would really like to highlight is we have a fantastic new tool, again provided by the European Commission, called the Clinical Patient Management System. It's just been upgraded by IBM, and we would love to test it with you. So if anyone out there in a hospital in the European Union would like to have a virtual cross-border NDT with our experts, we can facilitate that, and it's free. It takes about half an hour for us to guide you through how to use the completely secure system, and then you can upload the medical information and discuss the tricky case. We'd be delighted to test our new IT, so please do get in touch. You can contact us via the website. We also do education and training activities. We work on clinical guidelines, and more exciting, we have a patient registry. And at the moment, our network is 57 hospitals in 20 member states. So this will really help to tackle the fragmented and scattered nature of data on rare diseases. Once we have sufficient patient data, we can do more effective research, and more effective healthcare can be provided to these patients who really need it. So this evening, we've got another one in our very popular colorectal webinar series, and it's in collaboration with ERNICA, another ERN. We all try to work closely together. And it's about anatomical and prenatal studies in anorectal malformation. Our speakers are Dr. Nina Peters. She's a prenatal physician at Erasmus MC in Rotterdam in the Netherlands. We have Dr. Annelieke Schepens-Franke, and she's an academic lecturer in anatomy and embryology at Radboudumc University Medical Center. And we also have Dr. Yuichiro Miyake, who is Associate Professor in Pediatric Surgery at the Department of Pediatric General and Urogenital Surgery in that's a tricky one. Juntendo University School of Medicine in Tokyo, Japan. So we cannot thank these experts enough for being here with us this evening and sharing their expertise. And they're going to look at the latest techniques in prenatal diagnosis and the anatomical features of anorectal malformations. And they'll also emphasize how these studies impact decision-making, surgical planning, and the long-term care for these affected children. So thank you very much, and I'll give Annelieke the floor.
Okay. I'll share my screen. Share. I hope you can all see my screen now.
Yes, we can.
Okay. So thank you for inviting me. I'm happy to give you a talk about anatomy and development of the anorectal. I have to say that I'm a teacher in anatomy and embryology. I'm a biologist, so I'm not an expert in anorectal anatomy and development. So in this webinar, I would like to give you a short overview of my view on anorectal anatomy from the anatomical and embryological view, and also about the development and the malformation. And I also would like to address that terminology can be very complex and confusing. So I hope to keep it simple. And yeah, so if you have any questions, please feel free to ask them. So I'd like to address the functional anatomy of the anorectal. I'd like to divide on the development of the anal rectum, malformations, and also would like to ask you some questions that I'm not sure about, and maybe you have the answers. So when we start with functional anatomy of the anal rectum, just a short overview. So the GI tract, of course, is the GI tract which goes up from the mouth to the anal opening. Through peristaltic movements, food will pass through. In the end, in the rectum, it is collected, and there's a controlled passage if you're continent. And the rectum has two layers of muscles, a circular muscle in the inside, which creates the peristaltic movements, and the longitudinal muscle tube on the outside. And it's both smooth muscles. And the rectum goes into the anal canal, which is like a gate. So stool can pass or stay inside. And this is consisting of an internal rectal venous plexus, as you can see here in green, which works like a cushion, closing the anal canal. You have this internal anal sphincter, which is the continuation of the circular muscles of the rectal wall, which is also smooth muscles. And we have this external anal sphincter, which is skeletal muscle and is often divided into three parts, as you can see here, a cutaneous part and a superficial and a deeper part. And these are necessary for the gateway, so the continence. And there's a difference between the surgical anal canal and the anatomical anal canal. So in the surgeons, as you all are probably, they have a higher border. So it's where the anal canal is smaller due to the sphincters, which are contracted. While in the anatomy, we have this anal canal, which is only from the dental line, a dentate line, or the lower part of the anal canal. So it's smaller than in the surgical one. Then we also have this pelvic floor, of course, which surrounds the anal canal and which supports the pelvic organs. The main component is the levator ani muscle, and especially the puborectal muscle surrounds the anal canal and is also involved in continence. And then anatomically, you also have an area in between the internal sphincter and the external sphincter, which is sometimes called a septum, which is composed of the conjoined tendons of these longitudinal muscles of the rectum and the muscle fibers from the pelvic floor, which end up here in the subcutaneous part. So they like anchor the rectum and the pelvic floor towards the skin. During normal situation in resting phase, of course, the peristaltic movements make the stool go downwards towards the rectum. In this case, the sphincters, like the internal anal sphincter and the external anal sphincter, are contracted. And also the pelvic floor with the puborectal muscle is contracted. And during normal defecation, you feel sensory input, perception of stool in the rectum. So the rectal part is distended. And this leads to, when you try and want to defecate, if you're continent, you can relax your pelvic floor, anal sphincters, and of course, give some extra pressure by giving a deep breath and contracting your diaphragm and contracting your abdominal wall muscles. And also, of course, the rectum muscle itself, the muscular tube, will contract to have this peristaltic movement of stool. When you look at the anorectal anatomy, the border between the rectum and the anal canal was in this anatomical region. And this is because there's an anatomical division in the rectal part and the anal part. And you probably all know that the rectal part is from the visceral part, which contains smooth muscles and is innervated by autonomic nerves. And also the venous return is to the portal system, while in the anal canal, which is connected to the body ball, contains somatic muscles, skeletal muscles, like the sphincters and the pelvic floor, and is innervated by somatic nerves, which are under control of your own will, and the vessels that drain towards the caval venous system. So there's a difference in anatomy. And this anatomy you can see here in this picture better. So you have these visceral organs which are autonomically innervated, and after the pelvic floor and the external anal sphincters, these muscles are skeletal muscles from the connecting of the body wall and somatic, and also innervated by somatic nerves like the pudendal nerve. So this division is linked to embryology. So that's why I like to make the bridge to the development of the anorectum. So embryology states that the rectum, so the upper part of the anorectum, is developing from the endodermal gut tube in the embryo. So its inner lining is endoderm, the outer lining is splanchnic mesoderm, and this splanchnic mesoderm will form the circular and longital smooth muscles, and also the internal anal sphincter, which is smooth muscles. While the lower part, as you will know, is forming from the proctodial ectoderm, so ectodermal lining in the inside, and somatic mesoderm surrounding this, forming the pelvic floor and the external anal sphincters. And the line of union between these two is this pectinate line of dental line, the border in the anatomical anorectal region. So this looks like a simple diagram, but as you probably all know, the anorectum develops from another system like the cloaca. So in previous or earlier developmental steps, the anorectum is connected to the urogenital system. So I'd like to go to the urogenital system and the connection in the cloacal area. So this is a schematic drawing of the hindgut of the embryo, in which you can see the cloacal ending of the urogenital system and the anal canal. And it ends here in the cloaca with the cloacal membrane shutting it down from the outside of the embryo. So this is a common exit for the urogenital system and the GI tract. It's lined with endoderm, which forms the epithelial lining on the inside, and the glands, and it's surrounded by splanchnic mesoderm, which develops into the smooth muscles and vessels and connective tissue. And in order to get a normal development, you need this separation or splitting of the cloaca into a ventral part, the urogenital sinus, and a dorsal part, the anal canal. This is a very difficult step. So there are a lot of theories how this happens. One of them, the old one, is that there's a urorectal septum growing downwards, and this is the splitting of the urogenital sinus and the rectum itself. But there's new research that I saw an article in which they looked at mice and 3D diagrams of the developmental steps of this region. And they looked at the mesenchyme surrounding the cloaca and the growth of this mesenchyme. And they divided here. So this is the green area as the cloacal area. Here's the cloacal membrane. And they divided it into ventral, pericloacal membrane, mesenchyme, intermediate, and also the dorsal pericloacal mesenchyme. And they showed that for normal separation of the GI tract and the urinary system, you need a lot of growth of this ventral pericloacal mesenchyme and the intercloacal mesenchyme, while the dorsal pericloacal mesenchyme has to be a non-growing zone. So no growth. And when this normally happens, you get a normal separation of the anal canal and the urogenital openings. And this regulation, of course, leads to congenital malformations like anorectal malformations. When you look at humans in this area, this is a picture of a human of 7 weeks. And so already very late in embryonic development. Here's the urogenital sinus. You already see a lot of growth also in this area. So also in the human embryo, it seems that especially on the ventral side in the pericloacal mesenchyme is growing a lot. And research in Maastricht looked at this mesenchyme growing around the cloaca, and they've showed that indeed cloacal subdivision is determined by ventral growth. So especially ventral mesenchyme, as you can see here, so on the ventral side of the cloacal area, has to grow from the ventral to the dorsal side, also in between the urogenital sinus and the anal canal. And this ventral mesenchyme creates a lot of muscles like the external anal sphincter and the external urethral sphincter, and also the other structures here in this area. And they also showed that there has to be a non-growth zone on the dorsal side, just like in mice. So I was wondering, how is this linked to anorectal malformations? And I was just thinking, when you look at the classification of anorectal malformations, the latest type is divided by the Kirchenberg International Classification. I was a little bit confused by all the terminology, so I tried to make it simple. So I think when I look at the low type, there is the anal stenosis and the rectal atresia or the rectal stenosis. And there's also the situation in which the anorectal canal is ending somewhere in the cutaneous side. The cutaneous fistula, it's also called, in the scrotum or in the perineum. And there's also the high type or intermediate type, in which the fistula is between the anorectal canal and somewhere in the urogenital sinus, so rectourethral, in the bulbar area, prostatic area, or even in the vagina or in the bladder. So to me, from an embryological perspective, it looks like there's a separation, no separation in the urogenital system and the GI tract in the low type, while in the high type you have no separation or incomplete separation of the urogenital system and the GI tract, so the cloaca. And also important, I see often the type fistula, but I think when you look at embryology, it's more correct to call it not a fistula, but an ectopic anal canal, when you look at from the cloacal perspective and the no separation. So the cloacal didn't separate in the normal way, and the anal canal is connected to somewhere else in the urogenital sinus. So summarizing it up, what could be the causes then? Theoretically, I haven't talked about it, but the anal stenosis and the rectal stenosis probably has to do with epithelial adhesions in the anorectal canal, local adhesions that stay connected and causes stenosis. Of course, we've looked at the ventral pericloacal mesenchyme. I propose that reduced growth of this ventral pericloacal mesenchyme, which is somatic mesoderm in the sacral region, leads to an improper separation or no separation of the urogenital system and the GI tract. And it also involves the formation of the sphincters and the pelvic floor, just like we saw in the study of Maastricht. So this high type ventral pericloacal mesenchyme is missing, leading to poor sphincters in this area, while the cutaneous fistulas, as they are called, is probably an increased growth of this dorsal pericloacal mesenchyme. They studied it also in mice, and this could lead to a malalignment of the hindgut to the pelvic floor and the external anal sphincter. So when the dorsal side is moving too fast forwards, the anal opening is more to the ventral side and not well aligned to the pelvic floor, I think. And of course, there's also possible involvement of the growth of the hindgut, which could be reduced growth, leading to not enough mesenchyme and epithelial lining at the end of the anal canal, and this could lead possibly to an impaired internal anal sphincter, but I'm not sure. It's all speculative. So when this would be true, then there could be a role of anchoring fibers of the rectum in the alignment of the hindgut and the pelvic floor. I don't know if there's any information about it, but I think it would be nice to look at it. Also, the growth of the sacrosomatic mesoderm, which will form the ventral mesenchyme surrounding the cloaca, is very important in the development of this area. And I think it could have an influence on the formation of the high types of RM, the anorectal malformations. And this also explains the relation to sacral bone formation from somatic mesoderm, limb development in this area, secondary neurulation, vasculature, etc. So also very interesting, I think. Then I also had some questions. So when I look at embryonic and fetal development, I see that a lot of organ systems have to practice, during embryonic development to have a proper function. And I was wondering if during if you have a child with an anorectal malformation and you do the colostomy, if this could also affect the functionality of the pelvic floor and the innervation of the internal anal sphincter. So it would be better, I think, to operate sooner than later and remove the colostomy as soon as possible. Also, when you look at it, the functionality of the pelvic floor is very important for continence. And I'm wondering if people with high type of anorectal malformation, if continence is even possible, if there's not enough anal sphincter and pelvic floor muscles. And I'm wondering if you can measure functionality of innervation and muscle activity in these babies. I'm not sure. And can you even stimulate muscle function in early life? When they're under development. And I'm also wondering if you could prevent damage to already sparse nerves and muscles in babies with high type of RM. So, for instance, I saw this study in which they did a high pressure distal colostogram, and I was wondering, because I also give lectures about the pelvic floor and vaginal birth. And I was just wondering if due to this high pressure on the colon and also on the pelvic floor, you maybe could induce damage to these nerves and muscles in this area. And there's another one. So I saw an article in which they looked at the resected fistulas during the operation. So they collected the fistulas and looked at the anatomy of these fistulas, and they found that this often contains an internal anal sphincter. So it really looked like the end of the anal canal, and this would assume that indeed the rectal fistula is an ectopic anal canal. And I was just wondering if you measured this, or if you take care of it, and if you just remove the fistula, resect it, or maybe you can do something else with it so that you can spare this internal anal sphincter. So I had a lot of questions. I've learned a lot, and I think there's still a lot to learn. So I'm very curious about your questions. So I would like to give the floor to the next speaker.
Thank you very much, Annelieke. That was very interesting. I would indeed like to give the floor to Nina. She's coming up. Thank you. And we can discuss all of your questions, Annelieke, at the end of the webinar, see if people have the answers.
Hi, good evening. If I'm correct, then you now can see my screen. Thank you very much for the invitation for talking to you about the prenatal diagnosis in anorectal malformations. I think there are not a lot of prenatal physicians in this audience, so if I go too fast, please let it be known. I have nothing to declare. My slides want to go. Anal rectal malformations. It's been said, but it's a prevalence about 1 in 5,000. As you heard Annelieke tell you that their causes is still unknown. There's a lot unknown. There are a lot of questions, so I won't go into that. But it is associated with other anomalies, especially within the vectoral spectrum. And the question we get is it even visible prenatally? Because it's a very distal defect of the bowels, and the bowels don't do anything inside the uterus except develop. So can you see this prenatally? Well, in one of the questions we ask ourselves is, should we check the target sign, like the anal sphincter, in prenatal screening? Is that something we should look at? Because what you don't look at in prenatal screening, you don't see. So we did a retrospective study between 2014 and 2021. We included 115 postnatal ARM cases. And then it showed that 32 of them had a fetal anomaly scan, an expert fetal anomaly scan, where we look a little bit further than the supposed screening in population. And 22 out of these cases had an assessment of this target sign, of which 17 were abnormal. 5, though, did show a normal target sign, but these included, and I'm still learning, so fistula is not the correct term, as I heard just now, but these were not the complex cases. So in the cases where there was an abnormal target sign or absent abnormal target sign, these were the more complex cases. There are prospective data needed, obviously, because now we included only children with the ARM, and we don't know what the predictive value of this assessment is, but it sounds feasible to look at it. Then I want to take you a little small detour to the rectum, just because I'm going to show you a little image in a minute, because you can see the rectum prenatally. I don't know how familiar you are with ultrasound images, but this is a transverse view. This is the fetal bladder. And behind the fetal bladder, you see this rounded structure, which is filled a little bit with grayish sludge. In a long view, you can also see it elongated, but it has to end at some point. So it's a little bit like a fluid-filled tube behind the bladder. But if you see this, you should check reference values, whether it's within normal limits for the gestational age, because that bowel tends to develop, obviously, and also sizes increase with gestational age. So now we ask ourselves, is it very visible? Well, in first trimester, there's a study which showed that if you have an abdominal cyst at about 12 weeks, when we do the first trimester screening with ultrasound, and even if it is not seen later on in pregnancy, it is associated with more abnormalities, and often also with anorectal malformations. So if you see this at 12 weeks, 13 weeks, maybe you should repeat your scan at 20 weeks or 30 weeks to see if the bowel is developing normally. And if we again go to the second trimester, which is where we look more often, then we can look at the target sign. In this picture, you see the bottom half of a fetus. And so this is a butt cheek and this is a butt cheek. And this is a female fetus with the labia. And you see here that there's no interruption between both butt cheeks. And I'll elaborate on that later. You can also see, but that's more in third trimester, echogenic bowel content. So you see a bowel filled with more lucent substance with all these white dots in there. And that's a sign of urine mixing with meconium. It gives this very particular view. So when you see this, you should be thinking about an ARM. And also a fluid-filled uterus, which is also behind the bladder, which you obviously only can see in a fetus with a female phenotype, but it's more clear. So it's really clear liquid. And this is often because there's a connection between the bladder and the vaginal region where the uterus fills up. Also, this is something you see more in third trimester. Back to this target sign. We started looking at it in third trimester because then we could see it clearly. It's a little bit of a not so nice term because it looks like a target because it's a black ring with a white dot in the middle. And this is what it's supposed to look like. And then there was all this literature and they said, well, you can only see it in third trimester. And we started looking at it at 20 weeks. And I think early in second trimester, you can also see something forming like a ring, but it's a little bit less clear. Unless you start looking at it more often. This is a scan of a fetus where you start at the bladder and then move downwards. And then you see this region here, which does look like a target sign. But these data, we are still evaluating whether this is reliable or not. What we do know from our retrospective study is this is the normal situation. When the anal opening is missing or closed off, it's relatively easy because then you don't have a target sign. So you search for something that's not there. Be sure if you don't see it at 20 weeks to repeat the scan at 30 weeks because sometimes at 20 weeks it cannot be so evident. So maybe you check in third trimester when bowels start to develop for life after birth. This is a harder one when the opening is in the wrong place or it's too small because everything in a fetus is rather small. But if you gain more knowledge and look at it more often, you can see that the aspect does change because this is more ovally shaped with a more elongated white region in the middle. And if you look at this picture, then these are the labia of a female fetus here. And this structure is nearly touching. And you should see some skin in between. And then you have the anorectal malformations where there is a connection between the bowel and the vagina or the bladder. And then you get back to these signs, like the enterolithiasis, where you have these white filled spots inside the bowel, where the meconium is mixing with amniotic fluid or urine of the baby, or you see a fluid-filled uterus. I want to illustrate this on the base of a case we had when we first started. This was the first pregnancy. The first trimester screening for congenital anomalies and genetics were negative, so nothing came out. And the second trimester fetal anomaly scans showed a single umbilical artery, but that's it, which is something we see quite often, but gives a 10% increased risk of growth retardation in pregnancy. She was referred again at 29 weeks because of the amount of amniotic fluid, which was measured in the peripheral center as too much. And we saw her at 29 weeks and 5 days of gestation. We had no polyhydramnios, so the normal amount of amniotic fluid, the amniotic fluid index AFI was 19, within normal range. The baby was small for gestational age, but that could fit with the single umbilical artery. But the target sign was not conclusive. And if you look at these images, then this was what I was looking at. I thought, well, it's located, you can see something. You see a black ring, you see some sort of a white spot. Now, do this again. And also in the clip, you see that there's something there probably, but it's just off if you look at it a lot. But we were understanding, well, it's before 30 weeks, maybe it's just not developed yet or not developed enough. So we opted for a repeat scan. The repeat scan was performed at 32 weeks and 3 days. There was still no polyhydramnios. And they assessed the target sign again, and they said, well, it is a black structure. There is a white dot in the center, so maybe it is normal. From this case, amongst others, we learned when in doubt, check the anal region after birth. This baby after birth showed both an atresia of the esophagus, unfortunately, which is something we hardly detect rightfully before birth, but he also had an anorectal malformation. So what is the advantage of detecting it prenatally? Well, early detection means early referral to a tertiary treatment center, where you can offer multidisciplinary prenatal counseling about what to expect after birth, manage prenatal care, make a risk assessment, how high is the risk, can this baby be admitted to the labor ward with the mother, or we think, well, the chances are this high, maybe we opt for the neonatal ICU. And you can tell people about this, so they can prepare that there might be something, even when you're in doubt. So that brings me to my take-home messages. Take a look beyond the guidelines. The target sign, the rectum, it's not in the regular guidelines. But if you look at it more often, then you get a sense of what's normal and what's not. And then it makes it easier to detect when it's just out of the ordinary. Because if it's not there, it's not there. That's easy. But you also want to detect the more difficult cases which have the same problems. You obviously have to check for associated anomalies, especially within the vectoral spectrum. You offer prenatal genetic testing to see if there's something there. And I think the main message is, when in doubt, refer to a tertiary center, where we can offer multidisciplinary prenatal counseling by a fetal medicine specialist, a pediatric surgeon, the clinical geneticist, and neonatologist, and make a risk assessment of how to deliver best this baby, and what care the baby should get after birth. Thank you very much for your attention, and if there are any questions, I would like to hear them in the Q&A.
Thank you very much. We are moving over to the last speaker, Dr. Miyake. Welcome.
Okay, good evening. Can you see my presentation?
Yes, we can.
Yeah, thank you very much for the opportunity to present today. My name is Yuichiro Miyake, and I'm a pediatric surgeon at Juntendo University in Tokyo, Japan. It's a great honor to join this webinar. And since an excellent and detailed overview of the embryology and anatomy of the anorectum has already been provided in today's webinar, I will focus on the anatomical characteristics of anorectal malformation and discuss what pediatric surgeons should pay attention to during surgical repair. I have nothing to disclose. First, let me begin by reviewing the key anatomical differences between normal anatomy and anorectal malformation. Especially in high-type anorectal malformation, the rectum ends above the pelvic floor, and this feature has several important consequences. Because the rectum does not pass through the sling of the levator ani muscles, the muscle tends to be thin, hypoplastic, and displaced anteriorly. This is a crucial point to remember during surgery. When performing a pull-through, the rectum must be passed through the levator ani to restore a functional anorectal canal. In laparoscopic assisted repair, where the pelvic floor is not opened, it is particularly important to recognize this anterior displacement of levator ani to ensure the correct route is selected. There are also several additional anatomical characteristics associated with anorectal malformation. These include hypoplasia of the external anal sphincter and dilated distal rectal pouch, impaired peristalsis, and abnormal innervation of the pouch wall. The intrinsic neuromuscular function of this segment is often ineffective. Histological studies have shown reduced neural density and abnormal distribution of enteric ganglion cells within the dilated distal pouch. Because of these findings, some authors recommend resection of the markedly dilated distal segment to improve postoperative bowel function. Given these anatomical abnormalities, preoperative assessment of the pelvic floor plays a key role in determining the optimal surgical strategy for each patient. To better understand the pelvic floor structure, we performed MRI examination both preoperatively and postoperatively to evaluate the symmetry and angulation of the levator ani muscle in anorectal malformation patient, and we compared the findings with control subjects. Our study was conducted between 2018 and 2021 and included 14 patients with high-type anorectal malformation, 16 with low-type anorectal malformation, and 9 patients with Hirschsprung disease as controls. From the thin slice MRI images, we measured 3 main parameters: the mean thickness of the levator ani, and the left to right thickness ratio, and the deviation of the levator ani from the pubococcygeal line, which we refer to as the LA angle. The 3 groups were similar in terms of gender in age at MRI and body size, which we estimated by measuring the height of the 5th lumbar vertebra. However, the measurement of the levator ani showed significant differences. The mean levator ani thickness was significantly thinner in high-type anorectal malformation compared with both low-type anorectal malformation and the control group. Similarly, the LA ratio was significantly lower in high-type anorectal malformation, indicating that the levator ani was asymmetric. Moreover, the LA angle representing deviation from the midline averaged about 10.8 degrees in high-type anorectal malformation. Again, significantly larger than in low-type anorectal malformation and controls. In summary, in high-type anorectal malformation, the levator ani is thin, asymmetric, and deviated from the midline. Interestingly, we also observed that the pelvic floor can remodel and develop after surgery. This slide showed MRI images taken immediately after surgery and 4 years postoperatively in a patient with high-type anorectal malformation. Postoperatively, the levator ani muscle became much thicker and more symmetric, suggesting that if the pull-through passes correctly through the muscle complex and appropriate bowel management is maintained, the pelvic floor can gradually mature and regain function over time. In contrast, let me show you another cases that illustrate what happens when the pull-through is not placed correctly. This child has undergone surgery at another institution and later presented to our hospital with poor bowel control. MRI revealed that the pull-through rectum did not pass through the levator ani, but rather outside it. As a result, the child required daily enemas for bowel management. This case emphasizes how crucial it is to understand the true anatomical position of the levator ani and to ensure that the nail rectum passes within the muscle complex during operation. Further treatment options for this patient are currently under consideration. To conclude, I'd like to summarize the key points from today's talk. First, the pelvic floor in high-type anorectal malformation is significantly thinner, asymmetric, and deviated compared with low-type anorectal malformation and controls. Because of this, extra care must be taken during surgical repair, especially during posterior sagittal anorectoplasty to avoid injury to the levator ani. Second, Accurate identification of the levator ani and ensuring the pull-through is placed within it are essential to achieve good long-term functional outcomes. And finally, appropriate postoperative bowel management and training can help the pelvic floor develop and compensate for its initial hypoplasia. Thank you very much for your attention.
Thank you very much. I would like to invite the other speakers as well, so we can have the discussion section of the webinar. Let me see. So as mentioned before, you can type in your questions in the Q&A section, which is an icon somewhere down below in your screen. It has a question mark on it, so you can type in your questions. You can also raise your hand and I will open up your microphone so you can ask the question verbally if you want. I did notice that there were two rather comments in the question section. I think it was due to your presentation, Annelieke.
Sorry. Yeah. So yeah, it's a lot of speculations also about the high pressure. So the first question was, although I would seem possible, it's highly doubtful that a colostogram could induce damage to the pelvic floor. It should be done only once, and the pressure needed, albeit not measured, will fill the rectum and the fistula. In order to properly detect a fistula versus no fistula patient, the rectum should be properly filled, such as in the no pigeon cross-table X-ray filmed. Also, if according to the diagram showed, one would fill a rectum with too much pressure in a prosthetic fistula, it will distend above the levator ani and parasagittal fibers. Yeah. So it's above the levator ani, I know, but when the rectum is distended, it will, I think, will press against the levator ani fibers because there's already pressure from the diaphragm and the abdominal wall, etc. So there will be an increased pressure on the pelvic floor, and I don't know if it's able to measure and if you know if there's damage. I was just wondering if there's any information about it, because when you look at giving birth, it of course it's very more stretching of levator ani fibers, but it can give damage. And yeah, I would assume that when the pelvic floor is not correctly formed and has less fibers, I know there are not many fibers in a grown-up pelvic floor. Yeah, I think it would be riskful, but I don't know if you can control it or measure it or see anything about it. So I was just wondering it. I don't know if someone else knows the answer. Shall I go to the next question?
Yeah, that's good. Yeah.
Okay. Yeah. Yeah. So there was someone who said, thank you. I would like to know whether you have done post-mortem dissections of fetuses and checked the wall of the rectal fistula for muscle perinatal skin for anoderm and the position of the free parts of the external anal sphincter. Or are there others who have done so that it could discuss facts than just speculations? Happy to discuss further. Yeah, I don't know. As I stated in the beginning, I'm a teacher. I don't have the entire literature. I'm just wondering about things, and I would really like to discuss this with other people and maybe do some more research and dive into literature. So if someone wants to, cooperate, maybe we can find it out. So, yeah.
There is a question down below from an embryological point of view. What do you think of rectovesical fistula? I think maybe you have already discussed that during your presentation, didn't you?
Yeah. So I think the rectovesical fistula is really very high. So I think, but I'm not sure that then the ventral pericloacal mesenchyme, which will develop into the sphincters and also the pelvic floor, will be impaired, and this creates this cloacal opening embryologically to the urogenital sinus. And I think in these very, very high types, you also need an impaired growth of the anal canal, so the hindgut, mesenchyme, and endoderm. So it's a combination of the ventral mesenchyme around the cloaca as well as the hindgut itself, which stays behind in growth.
Right. I'm trying to look for the questions along the statements. Interesting to see that somebody mentions that in 1990 there was already a publishing about the things that we've demonstrated today.
Nice.
Yeah. There is also a question. From a clinical perspective, should the Crick-Beck classification still be used in anorectal malformation classification rather than the anatomical descriptive classification? Would somebody like to comment on that?
Yeah, I think from a clinical and surgical perspective, the Crick-Beck classification is still the most practical system because it is widely recognized and directly linked to surgical strategy and outcomes. So we're using that.
Have you by any chance published your results?
Yes, actually we published the study about the Radboudumc deviation or asymmetry in Pediatric Surgical International. So everyone can read it.
Ah, good. So you should be able to find it when you search for it. Let me see. There's somebody else that asks a question for Dr. Miyake. You made a reference to laparoscopic repair and anorectal malformations with the findings of MRI studies in your presentation. Do you think laparoscopy makes it easier to place the neorectum within the muscle complex?
Yeah, that's a very important point. And actually, we are using nerve stimulator both from the perineal side and the abdominal side to identify the center of the construction of the muscle complex. And preoperatively, we perform this MRI examination for all anorectal malformation patient. And we also review the MRI image together with radiologist to ensure the pelvic floor structure. So at the point of surgical view, laparoscopic operation is easier, I think, and to avoid the injury of the levator ani.
And what do you suggest about the dilated rectal pouch in improving post-absorbed continence? Excise?
Yes, I think so. We reject the markedly dilated rectal pouch because as I mentioned, the histological study showed that the markedly dilated pouch is not good nerve innervation system. So we dissected it.
I don't see any other questions yet. In the meantime, maybe some people have some last burning questions. I will do my usual announcements that the webinar has been recorded. So I will be sending the link for the recording to everyone who registered for the webinar tomorrow via email. For the people who attended live, oh, I see a hand raised. I will give you the floor in a minute. For the people who attended live, you can fill in the post-webinar survey that will be sent to you immediately after the session has finished. This way you can help us continuously improve our sessions, but you will also get an EACME certificate after 2 weeks. So I will now give one of our attendees the floor. I think you are, yes, you can speak
Can you
now.
listen to me? Yes.
Yes.
Hi, I'm Bruno Martinez. I'm from Mexico City. I enjoy these webinars a lot. It shows us a very different point of view from the European standard point of care. I actually remember Pim Sloots from a visit at Cincinnati Children's 12 years ago. Maybe you don't remember me, but I do. And I have a couple of comments about Annelieke's presentation. It raises very interesting questions regarding the functionality long-term about the distal colostogram. And it should be a matter of concern when you repeat the colostogram several times, because different settings and poor resource settings frequently they perform one and another, and it could damage actually the pelvic floor and the distended rectum and everything above. But as a surgeon, because I am mainly a clinical surgeon, I haven't seen damage to that. I mean, I expect a prostatic fistula to have very, very slim muscles, very poor contraction during the electrostimulator, very, very flat bottom. And I don't see that in patients with rectovulvar fistulas or rectoperineal fistulas that have repeated colostograms. Okay, this is anecdotic, of course, no? But this is a very interesting question you raised. The other very interesting question you raised was, how soon should we close the colostomy? That it should be an active point of research regarding when we should close the colostomy. As a personal goal, I tell to my patients that we should close the colostomy before 1 year. That's a goal we have before 1 year of age, one year old. Sometimes we cannot achieve that, but it also has some other things regarding anal dilatations and stuff like that that are beneficial for the patients. But yes, that's a very interesting question. I wanted to pinpoint while talking, because it's very, very interesting point of view. And I have enjoyed very much your presentations. And just an observation, this is a very Mexican point of view. Maybe I'm stepping on toes of Dr. Miyake, but I have never, ever 400 patients seen a deviated levator ani during the dissection. So I didn't have the chance to get your reference when you publish that. I would be very interested to very slowly read that report. And as we always say, a very meticulous dissection is key to preserve part of the continence, because I've seen a lot of people struggle with continence, and they think usually it is just a matter of a poor performed operation. Yes, it does, but it has to see with rectum, with the nerves. The nether images that you show are the same nether images I show to my patients, and also the type of fistula and the height of the rectum, no? And also back at this place of the pond, as you say, we usually don't use Krickenbeck. We usually use the anatomy description classification that someone asked in the chat, and maybe that is also a part of confusion within researches and reports and stuff like that. No? It's just a comment. I mean, it's very interesting to know that we are working on the same thing, but with different point of views. Thank you very much for listening.
Thank you. Thank you for your comment. Would anyone like to comment on that?
Yes, I could comment on that. Thank you, Bruno, for your critical remarks. So about the high pressure colostogram, I think you don't need such a high pressure that you damage the rectum. So if you give moderate high pressure, you can visualize very well the anomaly. And it's important as a surgeon to know what the anatomy is what about. So you should do this colostogram or an MRI. Nowadays we tend to go to MRI because it's easier for the patient, and it gives more information also about surrounding structures, not only about the lumen, but also about the other structures in the pelvis. You had a lot of remarks. I forgot about the other ones.
That's okay. Yeah, that's okay. Sorry to interrupt. We don't have access to MRI as maybe you can. That's a very important aspect to
I understand.
yes.
So you do the high pressure colostogram to get.
Yes, we rely on that a lot. I am a frustrated radiologist, I can tell you that.
And now about the reversal of the colostomy. So you need some time to let the wound heal, to check if there is stenosis, and to check if there is no damage to the rectum for the surgery, and then you can reverse the colostomy. I shouldn't wait any longer than that. Also for function.
I agree. Yeah, I agree with that. As soon as possible is
we'll be around
better.
4 to 6 weeks.
Thank you. Thank you, Bruno. I'm going to mute you again.
Yes, my dog is barking. I'm sorry.
So again, thank you all very much. I believe no other questions came in the chat either. So that was last question. I really like this feature, so I would highly recommend people raising their hands more often. So thank you all for being here. Thank you for the interesting presentations. I very much enjoyed it. And yeah, we will have another webinar next week on Wednesday. So see you then. Thank you, Mo. Have a good evening. Bye-bye.